Yeah. Very good. Very good. Well, I think we're a little bit past the hour, and we've got a number of people coming on. I see the rate at which people are joining is slowly leveling out. Maybe we'll go ahead and get started. I can start with just a couple of introductions first as people continue to join. But thank you all for joining us today. This is our Bleeding Edge Innovation Grand Rounds. And we have held these Innovation Grand Rounds for the last 6 months or so as really an opportunity for our community, our college, our clinical community, our campus, and all our friends to come together to really celebrate medical innovation and think about how we can combine the science, the technology with applications in medicine to really improve healthcare. The Bleeding Edge Grand Rounds are really meant to bring in external speakers that can serve as these role models and highlight people that have successfully been able to use medical innovation in new ways and to affect patient care. And so it's for that reason. Oh, there may be an echo. Maybe I can mute everyone. Maybe that helps. Okay. And so for that reason, I'm very pleased to present our speaker today, Dr. William Clifton. Dr. Clifton received his bachelor's in molecular biology from the University of Central Florida, his MD from the University of South Florida, and is currently a chief resident physician in the Department of Neurological Surgery at Mayo Clinic in Florida. He's also co-founder and chief design officer of the BRAIN Laboratory. And BRAIN is an acronym that stands for Biotechnology, Research, and Innovation Neuroscience. He has interests in material science and 3D printing for translational spine research and also for educational applications for resident trainees that we're going to hear about today. You know, I think we've heard many stories of inventors that have spawned wonderful ideas out of their garages. And but I think the story that Dr. Clifton brings to us started with a 3D printer in a bedroom. So it's, I think, analogous, but we're very excited to hear kind of where this has gone. So please join me in welcoming Dr. Clifton. Thank you for joining us. All right, I think if you can unmute, are you able to do that?
Can everyone hear me?
Yes. Maybe unmute.
Am I unmuted now?
There you go.
Okay.
Thank you.
Yeah, not sure what happened there.
Sorry.
Haven't had my hands on the keyboard, but we'll go ahead. Well, thank you so much for that introduction. I really appreciate it. And it's just an absolute pleasure to be able to talk to you guys over Zoom today. And I really wish I could be there in person. And, you know, I would have loved to tour your facility. I was kind of joking around with everyone last night when we had our call. I got the email and I looked over to my lab partner and I was like, is this supposed to be for me? Is this, you know, who are these people? I wasn't sure if it was real or not, but I got a chance to look at your campus online and everything about the school, and it's just fabulous work that everyone is doing there, both the faculty and the students. So today what I wanted to do for everyone was just provide a vision. And this talk is really meant for the medical students that are coming up right now and thinking about what they want to do for the rest of their life, where they want to go to residency, how they want to take care of their patients, what kind of research they want to go into. And I wanted to share my story and kind of where I started and what we're trying to do now. So the title of this presentation is Surgical Simulation as a Basic Science, a New Frontier of Research. So let's see if we can go forward here. So just a few disclosures. So I have a few provisional patents that are related to the research that are discussed in here. And I also have a GoFundMe page because I have 4 children and I'm a resident and don't make a lot of money. So you guys can hit me up after this is over. So now for the real disclosures. So in undergrad, I was a molecular and microbiology major. I did a lot of research in breast cancer cell line experimentation, and I was a biochemistry TA. So naturally, you would just assume how I felt about basic science research was the exact opposite. I absolutely hated it. I hated spending time in labs. I hated pipetting. I hated everything about basic science research. And for me at the time, it was just a means to an end. I was just a kid trying to get into medical school and just going through the motions and learning what I can and trying to make the grades, and really didn't have a passion for it. And then, fast forward a few years, I go to residency, and I get into medical school, and, I decide to go into neurosurgery, and, I'm in residency, and this is what I find that I love to do. I love to do spine surgery and make crooked things straight and help patients. And my chairman came to me during my research, or right before my research year, and he's like, Bill, it's great that you're doing all this surgery, but you really need to find a research interest. And, this research year is coming up, and I need you to think about what you want to do. And I'm sitting here thinking, oh man, if I have to sit in the lab again, or if I have to go through patients' charts trying to, publish papers, it's just going to be awful. And he gave me really great advice. He said, think about something that you love to do and make it better. And so I thought, well, I love to operate. I love to take care of people. How can I make that better and not have to sit in the lab all day? And so, that made me think, how could I get better at doing surgery and be doing research and making my chairman happy? And, Arnold Schwarzenegger said there are no shortcuts. Everything is reps, reps, reps. And, for surgeons, the more reps that you do, the more you're in the operating room, the more screws you put in, the more patients you operate on, the better you get. And that's basically how surgical training's been over the last 100 years. And so if you think about spine surgery, the way that we do spine surgery is very technical. And each vertebrae has different entry points, different ways that the vertebrae are organized. And this requires hundreds of thousands of hours of practice to be able to put screws into these small areas of bone without hitting the lung, without hitting the aorta, without hitting the spinal canal or the spinal cord. I was trying to find ways that I could just get more practice at doing this while doing research. And, it's easy to do this in a patient where their back is straight, but what about in cases like this? In case of deformity, we're looking at these pedicle entry points and they're kind of all over the place. So how can we get practice for these cases that are extremely rare, but when they come, what do you do? Maybe you've only done 10 of these. Maybe you've only seen 10 in your entire life. How do you get good at these? And so that made me really think about, how can we curve this bullet? How can we create something or find a platform that I can train on and maybe just, publish some papers. So that's kind of where it started. So there's some major issues facing neurosurgical education that I discovered while trying to plan all this for my research year. That resident live operating room experience is decreasing compared to previous years. And this is true both in the United States and abroad. There's a recent paper that came out in Active Neurosurgery, and basically what it showed was that residents that have operated over the last generation come out and they really don't know what they're doing. They showed decreased patient outcomes, especially in Europe, compared to previous generations. And this is partly due to resident work hour restrictions and just the amount of exposure that they have to these really tough cases. And the problem with this is that rare cases are rare. Neurosurgical incidence of diseases are on the more rare side compared to the other surgical subspecialties. If you're interested in general surgery, you're going to take out 1 million gallbladders. But, if you're doing neurosurgery and you want to do scoliosis, you may only see, 5 to 10 scoliosis cases in your whole residency. And the case volume needs are different for every learner. And this is something that I've learned over the last 10 years of doing this, is that some people are going to need to just do 1 and then they're going to be great at it. Other people are going to need to do 100 and be great at it. So neurosurgical training and surgical training in general is really tailored to just a broad audience. It's not individually tailored to the learner. So then I started looking at, okay, well, what do we have available to us that I could look at to 1, do some research on, and 2, just get better at doing spine surgery. And, they have some models out there that were okay, kind of got the gross anatomy. And then, we could obviously use cadavers. We do have the facilities here where we can use cadaveric tissue. And then there's some VR applications, but they really don't feel that great. And it's just kind of like you're, sitting at home playing Xbox. You don't have that intraoperative feel of the tissue and all the steps of the surgery. And not to mention, all this stuff costs so much money. And I told a story to everyone last night. I decided just to start using cadavers because that was the closest thing to real life. And it was about a quarter of the year, and I got flagged for spending almost $100,000 in human tissue. So I had to go apologize to my chairman and say, oh my God, I'm so sorry. I did not realize how much, money these things cost. And, he said, well, if you're going to keep doing this, you either got to get a grant or you got to find a better way to do it. So that really fueled my interest in figuring out how could we replicate human tissue without actually using human tissue. Because it was about $5,000 just for one cadaver. So then I thought, what are the fundamental questions of simulation? What are we trying to do? Because before this, simulation to me seemed kind of hokey. It seemed like people were just kind of putting makeup on and acting sick, and we were listening to Heart and Lungs and saying, yeah, you did a good job. And how can we make this real? So the first question is, what experience is meant to be brought to the learner? What are you trying to get out of the simulation? And what learning points are being taught? So there's literature to show that having very specific learning points for each simulation confers a better learning opportunity and outcomes for the patients or for the students that are involved, rather than having a broad simulation that kind of covers a multitude of topics. And then the last question, and this is the one that I think we're still going to be struggling with for a long time, is what is the fidelity or the realism of the simulation? And the second part of that question is, how do we determine that what we're seeing is actually going to translate to outcomes both for resident education and for patient outcomes? So looking at fidelity in just surgical simulation, which is really my area of interest, there's three components. So there's the anatomy, which is the shape of what you're trying to recreate. There's the physiology, or how the shapes move in relationships to each other. And then there's the dynamics. And the dynamics has to do with not only setting up your operating room and your tools and the people that are around you, but just the overall flow of the surgery. So even when you're operating on a cadaver, which has very similar properties to regular human tissue, the workflow and the tools that you're using aren't the same. So that muscle memory that you're creating may not be of great benefit when you actually hit the operating room. And this is getting beyond just looks. It's easy to make a pretty model. There are $500,000 3D printers and there's special effects artists that can make things look really good. But on the inside, what is the physiology of those models? What is the material science behind those models that will actually confer a reliable experience to the people that are using them? So I just took this and made it very simple. I said, how can we make a vertebrae that I can operate on and put a pedicle screw in that's going to feel like an actual vertebrae in the surgery? And I just started with that. So there are several components to human bone that we looked at. One is just the gross anatomy and the overall shape. And then there's two components. There's a cortical bone and cancellous bone. And here I have an x-ray of a vertebrae. And you can see that the spinal canal, which is that circle in the middle, that bone that's covering the spinal canal is 2 to 3 times thicker than the outer wall of the pedicle. And then that inner bone, that cancellous bone or the marrow, is very, very loose, and it's bloody and it's just kind of soupy. So as you're putting your screw in, you can feel when you're going to violate either the spinal canal or laterally, because you feel something hard and you can kind of work your way in and find your way into the vertebral body. And so I thought, hey, if we could design a vertebral simulation that could teach residents that haptic feedback, maybe when they hit the operating room, their screws will end up in the right place, and they won't have to replace them. And this is called the ventral lamina concept, and that's a pretty well documented concept in spinal surgery. So we just started with the surface anatomy. So the facet interfaces of the vertebrae, how do they interact with each other? How does each level interact with each other, and how can we recreate that? And then also the pedicle morphology and the structural relationships between the pedicle and where the thecal sac would be, and where the lung would be, and where the great vessels would be. So there are a few different ways that I found that I could probably recreate this. One's with injection molding, and that's basically where you take any sort of thermoplastic or other material that dries, and then you create a reverse mold of it, you inject the stuff in, and then it fills, and then it dries, and then you get a cast. The problem with that is that, number one, it takes a long time to do that. And then number two, you're really only using one material. So you're really only getting an external shape, and the shape may not be that great because it really depends on how well you made the external mold. So it seemed like a lot of steps to me. And there's a company out there that does this called Sawbones, and then you may use that in your medical curriculum, which is great for learning surface anatomy, but it really doesn't feel like bone when you're operating on it. And then I heard about 3D printing. And 3D printing is really great because you can get micron level detail of the surface structures of not only bone, but all other soft tissue structures as well. And there was a lot of different filaments and thermoplastics and resins that I saw that I thought, man, if we use some of these, maybe I can, make this not only look like a vertebrae, but feel like a vertebrae too when we're operating on it. So I started to look into 3D printing, knowing nothing about the subject. And I found out there were basically two different types of what's called desktop 3D printing. And the first one was called FDM, or fused deposition modeling. What that is it's basically like a fancy hot glue gun. The filament goes into the nozzle, it melts, and then it goes back and forth on a bed, which descends, and then it builds whatever structure that you're trying to make. The other type of printing is called SLA printing, or stereolithography, and that basically uses a laser to cure a resin that's liquid, and that turns into a rock hard model. There's different types of resins that you can use that can be soft or hard, and just kind of depends on what you're trying to do. So looking at both of these and their pros and cons, I really tended towards FDM 3D printing just in my thought process for what we were trying to do to make bone. There was a diverse thermoplastic selection, a lot of different shore hardnesses and material makeups. It can still get micrometer level detail like the SLA, but it was very, very cheap and inexpensive. And so I took this idea to administration. I said, hey, I really think that we could turn this whole simulation thing around. We can invest in a 3D printer, and I could just figure out how to use it, and we could just see where it goes. And they were kind of like, whoa, let's just pump the brakes here, Bill. You don't have an advanced degree. Where are we going to get the personnel to do all these things? Not only run the printer, but do maintenance and software. How are we going to maintain this project? And who's going to pay for all this? And so I came up with a very reasonable budget, and still the answer was no. So, I thought really hard about this, and I said, it's just wrong that we keep spending so much money on human tissue. Like it's wrong that we're paying $5,000 for a cadaver that we use for 30 minutes and charge it to the department, which is really coming out of our patient care budget. So I just took out a personal loan, and then got online, and then found a 3D printer, an Ultimaker S5, and then stuck it in my bedroom and just started experimenting with it. And I thought, hey, the worst thing that could happen was I just make cool Happy Meal toys for my kids, and then maybe they'll have fun with it. So, I really, my first few prints, were very challenging, because I realized that not only do you have to understand the material science and the material properties of the filaments that you're using, but there's so many factors on the computational side and the software side that control the printer, and then factoring in the environmental factors of ambient temperature and humidity that go into making these prints. And there's really a science behind it. And, I just kind of went on YouTube and looked up a bunch of YouTube videos and used my background in engineering and organic chemistry to, just kind of flounder my way through learning how to do 3D printing. And then, I thought about, well, what are we really trying to make with these vertebral models? And we're really trying to replicate that corticocancellous interface that I talked about. And no one had really done anything before we had tried to do this. A lot of people were using the injection molding, making their simulators, or they were doing reverse molding with fiberglass, trying to recreate this. And I thought, man, FDM 3D printing would be great for this, because there's filaments that are really, really hard, and there's filaments that are on the softer side. And if we can get those filaments to stick to each other as we're 3D printing them, then maybe we could just create a file that we could print it out for the residents, have it laid out on a table, and just say, hey, put in screws in this so you can see what it feels like. And the composition differences between the corticocancellous interface, I thought I could replicate with FDM 3D printing. So this went back to hypothesis-driven research. Taking a step back and saying, what is my hypothesis? How am I going to carry out the experiment to either prove or disprove my hypothesis? And this is really one of the main problems that I found that had me disillusioned with academic medicine before I was getting into these projects, was everyone just publishes their good results. Everyone's afraid to publish negative results. And when they try to publish them, they get rejected from these journals. And a lot of the 3D printing articles are very marketing driven, they're industry driven, and you could just tell there was some financial backing to them. There wasn't a lot of hypothesis driven research behind it. So I said, no, we're going to be different, and we're going to do it this way. So my hypothesis for this first experiment was using 3D printed thermoplastics with different density properties would allow for a haptic feedback similar to human bone during screw placement. And I decided to use two different thermoplastics, polyvinyl alcohol and polylactic acid. And so I designed this honeycomb sort of pattern within these vertebral models using PVA on the inside, which has a lower density than the PLA on the outside, to try to simulate cancellous bone. And we got this published, and this was a really awesome paper, and it actually gave the residents a pretty good experience on haptic feedback of learning where your screw is going, and if you're going to violate a cortical surface, of how dangerous that is and what that would feel like in surgery. And you know, these things x-rayed, and we could judge the residents based on their screw placement, and we could determine their skill level before they went to the operating room and they were able to operate with the chief resident or the attendings. So we kind of knew what their skill level was to allow them to be safe in the case. So this was really cool. And I thought, man, I'm like the best at 3D printing ever. And then the residents started to get really into it. So the problem with this technique was the print time was about 8 hours for one vertebral model. And I was paying for all this myself. So I was sitting there in my bedroom. We had just had our 4th kid. You know, my wife's rocking the baby in the middle of the night. I'm waking up to clean a print off the print bed thinking, oh my God, the PGY3 tomorrow is going to want to do, you know, 20 screws. And then we have the case the next day. And I really want them to practice, you know, how is this going to be sustainable? And so there's this escalating use of simulators from the resident. And the bad part about this was it was really limited to one bone type. And what I mean by that is you couldn't replicate people with really, really hard bone, and you couldn't replicate people that had really, really soft bone, like patients with osteoporosis. So when you get into the surgery, if you had a patient that had, you know, a bone density that wasn't really within the normal spectrum, you know, the residents and myself were kind of like, well, I don't think that simulation really helped me here. I mean, I understand what it feels like when it's normal, but what about those rare situations like we were talking about at the beginning of the presentation? And the laminectomy simulation, anytime we drilled the bone, it really wasn't that great. You could see those honeycombs. It didn't really look like bone or feel like bone when they were wanting to drill it and practice those techniques as well. And this is really interesting, actually. And what we found is that when we upsized screws within the pedicle, the filaments would actually crack. And that's because of the layering effect that the FDM filament has. So those filaments, when they deposit on each other, they melt. And as you put the screw in, it would split the whole vertebrae. And if you didn't put that screw in just perfect, you know, it really wouldn't behave like normal bone, because normal bone, if a pedicle is shaped like this and you put a round screw in, it will actually expand to accommodate the screw if you place it in the right location. So even that part of the simulation really wasn't that great. So I wasn't really happy with that. So we decided to keep on working on it. So we went back to our lab and we said, okay, what's going to be our hypothesis-driven research for this? Lab meaning my bedroom. A polymer or polymers with similar material properties to cortical cancellous bone would provide a high fidelity representation for spine surgical simulation. So I thought, you know, I really like this 3D printer. I invested a lot of money in it, but maybe 3D printing isn't the answer. Maybe there's something else out there that I can combine with the 3D printing to make what I'm trying to make for the residents. And then that's really where the question came in. Am I using the technology, or is the technology using me? And I thought about that, and I thought, am I just doing this because it's cool to 3D print, or it's fun, or I like the technology, or it's sexy, and people are accepting my publications because I'm using a 3D printer? Or am I doing this because it really is conferring a benefit to these residents who are using the simulation? And you know, I really had to take an ego hit there and say, no, I think that there's something else out there that's going to be better than just using 3D printing for this, even if it costs me some publications. So I went back to the basic bare bones, no pun intended, material science of creating cortical and cancellous bone. And we looked at biomechanical investigations on human tissue. We looked at histologic investigations of the lattice density and porosity indices of cortical and cancellous bone. And then we thought about the polymer science. What polymers are out there that are porous, that are light, that can replicate what we're trying to replicate? And so after going through a few, we found this one called polyisocyanate, which is a type of foam that's used for insulations and other things. So it's a porous polymer, and its density range actually falls within the ranges of normal cancellous bone for human patients. And when this substance polymerizes, what it does is it releases CO2 gas. And the CO2 gas makes these little bubbles that go within the foam, and it has a sort of random pattern, but the overall porosity index of the cured foam actually has the same porosity index as normal bone. And we found that we could actually tailor the polymerization based on the number of reactants that we had, that we can make these bubbles bigger or smaller, so we could really replicate patients that had weak bone like osteoporosis, or really, really hard bone like younger patients or pediatric patients. And so that was really cool. And so we decided to implement this within our 3D printed vertebrae. The 3D print was great for making the overall structure of the vertebrae. We got micron level detail, and we could make it very patient specific and situation specific. But on the inside, it wasn't doing a great job. So that's where we actually did an experiment where we combined the foam with the 3D printed filament and the prints to see if this would replicate our screw placement in a human being. The problem with polyisocyanate is that it's extremely exothermic. So these thermoplastics rely on heat to form their shape. So we weren't sure if we could find a filament that would have the same material properties, such as density and shore hardness as cortical bone, that could tolerate that exothermic polymerization within a hollow 3D printed vertebrae. And so this video here is an experiment, and what we did was we used two different filaments that had the same shore hardness and density as cortical bone, PLA and acrylonitrile butadiene styrene. And you can see the PLA has a lower melting temperature, so that bent and deformed when the foam polymerized inside of it, or the ABS constructed and kept its entire shape, and the foam was able to fill all the crevices inside of it to make a cancellous interface. And this is a fast motion video, so you can see that after we fill it, this is a PLA vertebrae, it just completely erodes through. The model, it just shrinks, and the heat just completely destroys the 3D print. So we actually got this published in a Nature subjournal looking at this for replicating cortical cancellous interface, and we put in a couple hundred pedicle screws in a lot of these vertebrae, and we showed that this had the same feel, touch, and even behavior of human bone by combining these two polymers together. So that was a huge leap forward in simulation for pedicle screw placement for the residents, and also for laminectomies and all other spinal procedures. And we got a patent based on this simulation, which is now undergoing industry funding. So, we were really, really excited about this, and this was really, really cool. So we hit the anatomy, we hit the physiology, but we were missing something. We were missing the dynamics. We had these vertebrae, and they felt exactly like a human vertebrae. They looked like a human vertebrae, and the residents were loving it, but it was too easy. I mean, you're trying to put a pedicle screw in, and you can see the pedicle, you can see all the landmarks that you're supposed to do, but that's not what surgery's like. Surgery is a dynamic sport. There's blood in your way, there's soft tissue in your way, skin, fat, muscle, and our normal patient population, it really isn't that thin. So we're having to work around a lot of structures to try to visualize exactly where we're placing these pedicle screws in these vertebrae. And this is not a new problem. So there have been a lot of papers that were looking at trying to replicate soft tissue, either with ballistical gel or with other types of foam or with silicone. The problem with those is that they're not compatible with electric cautery. So they would just kind of go down, they'd rip it apart, and then there would be the vertebrae. But you can't use the same tools that you use in the operating room. So the workflow wasn't the same, and it kind of threw the residents off and didn't build that muscle memory like you had to have in surgery to do a good job. So simulator fidelity, what we wanted to do is provide a work in a whole environment for the residents and have different elastic compositions. We wanted to try to find something that could replicate skin, try something that could replicate fat, and try something that could replicate muscle. And have all those layers together that the residents had to dissect through, expose themselves, so that if they made a mistake and didn't expose enough, that their screw wouldn't end up in the right place, just like it would in the operating room. And then our hypothesis was that would translate into better resident outcomes when they're actually doing the surgery themselves. And the big part of this was finding all these things, and it was conductive and compatible with electric cautery and wouldn't blow up the entire simulation center. So that goes back to our hypothesis. So a conductive, flexible polymer would provide a base material for soft tissue simulation and enhance our spinal surgical simulation that we already had with our vertebral models. So we looked at what was already out there. There are probably 1 or 2 papers that were published looking at polyvinyl alcohol hydrogels to replicate soft tissue because they're conductive and they're flexible, and you can kind of tailor the properties based on what you're trying to recreate. But the problem with these is that they're expensive, they're unstable in water, which isn't great because you're constantly irrigating during the surgery, and so you kind of dissolve them away, or other hydrophilic liquids. And the way that they were polymerizing the polyvinyl alcohol to recreate these soft tissue structures was using a freeze-thaw method. So they would take the PVA, they would put it in a solution, then they would put it in a sub-zero freezer and then bring it out and then put it back in and take it out and put it back in. So they're using a thermal polymerization method, and the number of freeze thaws that they were doing would translate to the elasticity or different properties of the simulation. So it would take up to a week just to build one simulator. And so, I looked at that and I said, wow, polyvinyl alcohol is pretty cool, but that just seems like a lot of work for one simulation. And at the end of the day, are you really saving that much money having to get a sub-zero freezer and use all these different techniques, and it would take 5 people to build one simulator? Are you saving anything, or should we just use cadavers at that point? So we went back to the lab again. And I was thinking about this for a long time, and I was feeding my son one night, and I was feeding him spaghetti, and the spaghetti just splattered on my plate, and I looked at it and I thought, why are we spending so much money on all of these crazy chemicals? And I was still paying for all this myself. And then at this point, I had met someone, my lab partner, who was also pitching in and helping me, and we were trying to develop this together. Why are we spending all of our money using this stuff when it's got to be something easy? There's got to be things around the house or materials that you can buy at the supermarket that we can create to make this polymer. It can't be that hard. So I had a very tailored interest in organic chemistry back in college, and I TA'd for a number of years and worked in the organic chemistry lab and taught organic chem for MCAT prep. And I didn't have a formal degree, but it was always a hobby of mine. I really enjoyed it. So I wrote down a couple structures that I thought I could replicate just by using inexpensive compounds. And this picture that you see here, which is kind of a cool, ironic picture, this is the actual napkin that I used to draw out my compound. That was our hypothesis, and then this was the end result. So we worked really late one night, and we tried a bunch of different things, and we laid them out, and we came back the next morning, and lo and behold, we had the compound that we were looking for. I mean, it was pretty incredible. It was non-toxic, it was biodegradable, has a high conductivity, it was compatible with electric cautery. The polymerization process was done in seconds. It wasn't done in days. There was no need for thermal polymerization. It was completely non-thermal. We were using all or inorganic reactants. And we found that we could actually tailor this to the desired tissue properties. So we could use the same base polymer and make skin, fat, and muscle, and we could color it any way that we wanted, and it would actually behave exactly like those tissues. So this to me was just tremendously exciting, because I thought, man, all these people said you need an advanced degree and you need to hire an organic chemist, and you need to hire a biomechanical engineer to do this. And before I knew it, I had just pursued what I was passionate about and what I thought was just really cool and interesting. And we had developed something that no one had ever developed before. And we decided to continue to use this and build simulators. So this looks like an operating room setup. This is actually one of our simulators.
Construct the finished simulator.
And so you can see, let me see if I can go back here.
Construct the finished simulator.
And so you can see here the resident is
midline fascial plane,
making a midline incision. And this is one of the instructional videos that we made for the residents that they watch as we're doing the simulation to instruct them on how to do this surgery. So you can actually see that there's skin, fat, muscle. The resident is using electric cautery. There's actually tendons attaching to the bones. And as the case moves on, they can scrape off all the degenerative process off the 3D printed vertebrae that we use. All the anatomic structures are completely intact, and we can actually show the residents how to do these very complex surgical techniques and screw placement, and it actually looks and feels just like it does in the operating room by combining all these processes, by combining the 3D printing with the polymer science, and then with this new polymer that we created.
Instrumentation can be drilled.
And then the residents can also practice multi-layered surgery. So they can do laminectomies, and we can actually see how much pressure they're putting on the spinal cord and how they're behaving before they hit the operating room. So, in 2020, there's really no excuse for someone who's never done a procedure before to be learning on a patient. And since cadavers are too expensive, this may provide a way for us to determine resident skill level before they go into the operating room to determine, are they ready to scrub into this case? Are they ready to try to help this patient? Is there anatomic understanding there? Is there understanding of the instruments of the case there? And allowing a start to finish simulator to be done and built within a couple minutes and cost less than $20
can be placed.
Was a huge
simulator
leap
is
forward.
compatible with fluoroscopic.
And then we could also take x-rays and
in
see where
order
their
to
screws
assess
ended up. And if
hardware
there wasn't a screw in the right place, we could have the resident interpret and say, hey, where do you think that screw is? And you can grade them on that as well. And we also did this for lumbar spine and thoracic spine as well. And you can see this is one of the residents that's doing a laminectomy. And the ligament actually ends at the superior part of the lamina, so we can judge, hey, did you recognize that? Or did you take a bite out of the dura and get a spinal fluid leak? Or did you damage the nerve roots? And we can see what kind of instruments they're using and how ready they are to do this procedure in the operating room. And the great part about using the 3D printing for these simulations is that the anatomy is exactly how it is in a human being. The angles are the same, the working angles for your instruments are the exact same, and the relationships between all the structures are the same. So violating one structure, leaving another structure intact, it's the same in these models as it is in a real person.
So Dr. Clifton, one question that came through the chat, maybe just to clarify, are all the tissues in that video simulated then?
They are. They are.
Very cool.
Yep. So that the start to finish simulator is constructed for about $20, like I said. We use a base polymer and then we layer it over our 3D printed vertebrae, and we do that in a way that complements the anatomical structures of not just the bone, but the soft tissue, which had not been able to be done before all this.
So we're seeing, that's very impressive. That's so cool. Wow. From the audience.
I will say this, selfishly, I got more out of this probably than anyone because I actually practiced on my own models and I could tell a difference walking into the operating room. I said, I want to get better at laminectomies. I'd build a model and do 20 laminectomies in one evening. And I walked in the operating room and, you know, even my boss was like, wow, Bill, you got a lot faster after doing that. And I was like, yeah, I guess I did. I guess I did. That's pretty cool. And, you know, this is another simulator that we built, and we decided to get a little more fancy with this one. So you can see that this one actually ultrasounds, and this is simulating a tumor surgery that we do for lumbar spinal tumors that are wrapped around the nerve roots. And for this, we could actually, you can see in the A corner, the top left-hand corner, we can actually stimulate these nerve roots and they would turn on LED lights, and we could have the resident determine, hey, which nerve is this tumor coming from and how did you spare these nerves? And if you manipulated the nerves too much, the LED lights would go off or they wouldn't work anymore, and we'd say, hey, you just ripped that person's nerve root out, congratulations, you know, you fail. And then we could say, try it again. And not only that, but we can also grade the resident's microsurgical skills. So all this is done under a microscope. The other parts of the surgery are done just with loupes or with just regular glasses. It's very gross, certain gross, I mean huge, but it also is very gross. There's blood everywhere. You know, you're hacking things to pieces. That's scoliosis surgery. But these are very fine movements, and we can judge the resident's operative skill, how much they shake, how they move their wrists and their hands. And, you know, not just to judge them and say, you're not cut out for this, but more to say, hey, put your hand here, move your wrist here, turn here. And you're not doing it in the middle of a very intense, very complicated surgery where there's a live patient on the table and you're losing your patients because you're trying to teach somebody that doesn't know what they're doing. But you do it in a simulated environment on a $20 simulator. And then if they mess it up, then you take it, you build another one, and then you start over again. You do it till they get it right. And, you know, our residents have really improved in their skills before they've hit the operating room. And I've had several of the attending physicians say, this is the best cohort of residents I've ever seen come through here. And I'm thinking, yeah, they practiced for like 2 weeks straight before they started, you know, on the simulators, and they already knew how to do a lot of this stuff. So the level of detail that we're able to get to, and, you know, the different parts of the simulation that we're able to recreate have really gotten much more high fidelity. So this is an example of another one of our models. This is not a human being, it's not a cadaver, that's one of our surgical simulators. So, you know, these cost-effective simulators, I think, are really gonna represent a new era of not just neurosurgical simulation, but simulation for all surgical specialties. So right now we have 10, actually more than 10 now, fully functional simulators that the residents use on a regular basis. We have 20 more prototypes in development, not just for spine surgery. We do have them for brain surgery as well. We have a brain model that residents can use to dissect out the sylvian fissure, to take out tumors, to determine how much they manipulate the brain, to determine how they respect the blood vessels. All this done under the microscope with, you know, 10 times magnification at that level of detail, which is really, really fun and incredible. And now we're working on industrial partnerships to make this available and cost effective so that not just residencies can use this, but medical schools as well. And I talked a little bit about this before I think a lot of people got on the call, but one of my main interest in research is, how do students understand what they want to do before they know what they want to do and before they do it? Because I'll tell you right now, I didn't always want to do neurosurgery. Actually, in medical school, I wanted to do OBGYN. I was dead set on doing OBGYN my entire medical school career. And, I walked in and saw my first GYN patient, and I thought, there is no way I'm doing this for the rest of my life, because I had never done it before. I liked the idea of it, but the day-to-day wasn't really my style. It wasn't fitting with what I wanted out of my career. And I had always been told, those neurosurgeons, they're so grouchy and they hate each other and they're mean and they never see their wives. And, and so I just had this really disillusioned view of what neurosurgery was until I actually tried it. Till I was a medical student, 4th year, hopped in a case, and I thought, this is what I want to do. This is amazing. And I had just thought, if I had known that back as a first year or a second year, how would my research interests have been tailored towards that specialty? Or how would I have been able to understand more about what I wanted to do? And how would that have shaped my career? Just because it wasn't available. There was no way for me to do that until I had the opportunity. So that, to me, is going to be, I think, the best part of these simulators, is having them in places, not just to teach people how to do surgery, but just to see if they even like it, just to see if they want to do it. So this was one of our brain surgery simulators that we made. So this is a resident trying to take out a brain tumor and then getting into a bunch of bleeding and then trying to control it. So, we've gotten to the point where, if you pull too hard on tumors, or if you, manipulate vessels too much, you get into situations where, hey, what are you going to do in the operating room when this happens? Are you going to freak out? Do you know what kind of clips you're going to reach for? Do you know what you can cauterize and what you can't, which vessels are important? So there's a lot of higher level decision making that we're also able to assess with these new simulators that we're developing. So what did I learn through this entire experience? What were the things that I took out of it, other than the fact that I invented something cool? As a physician, basic science is really part of your soul. And, in undergrad, they force us to take all these classes in biochem and organic chem, and it comes really easy to some people, and some people it doesn't. But at the end of the day, what you do in your daily profession is based upon the fundamental knowledge that you learn in those classes. And especially in medical school, learning the basics of anatomy and physiology, understanding all the cerebellar cortical connections, all the things that just seem so mundane and a grind when you're in medical school, they really have an impact on how you take care of patients once you're done. And maybe not in the exact things that you memorize, but it's just like training. When you do bench press and you try to make yourself strong, you don't go out in the field and you don't bench press, but it makes your chest strong, makes your triceps strong. It's flexing your brain to be able to accommodate what you need to learn when you actually do get out in the real world and you start taking care of people. And then getting back to the basics, not being disillusioned with or just infatuated with technology and saying, well, I'm just going to use this because it's cool and I got a grant and I paid a lot of money for it. But saying, what are we really trying to replicate here? And being very self-critical and thinking, is this cool? Am I doing a good job? Am I really teaching somebody something that's worth teaching? Or am I just happy because other people think that it's cool or think that it needs to be published and I got 20 papers out of it in a year so I'm just going to keep doing it? What's your motivation behind it? And then don't fall into aesthetics. Just because something looks good doesn't mean it is good. That's true with simulation. That's true with your career in medicine. That's true with the people that you surround yourself by. It's all about what's on the inside that counts. And just remember, the only person that you are destined to become is the person that you decide to be. You're going to have a lot of people telling you no. You're going to have a lot of people telling you can't do something. You're going to have a lot of people telling you that things are impossible. But if you decide that they're possible, you can do it. I know that sounds kind of funky, especially coming from a neurosurgeon, but it's true. And I didn't believe any of this stuff before I came to residency, but over the last 7 years of training here, I've really come to understand the only difference between people that are successful and the people that are not, it's not brains or talent. It's just a matter of how bad you want it. So this is a paper that actually just got published in JAMA Surgery, kind of talking about some of these topics. And I used Lord of the Flies as kind of an alliteration to medical education, and how residents are just kind of abandoned. Medical students are just kind of abandoned. And a lot of these millennial surgeons and millennial doctors that are coming out just kind of feel like, hey, I'm just kind of left alone and I'm not really being taught anything. But just remember, when you get out and practice, when you see a patient, when you have a complication on a patient, that's on you. There's no one there that's going to back you up. There's no one there that's going to to be there to pick you up. It really does come down to what you put into your medical school, what you put into your training, and how hard you're willing to work, not just to make yourself better, but to make the people around you better too. And that's a very hard thing to do, because I think in this culture, we're surrounded by making comfort and idle, saying, you know, I'm okay with committing to this as long as it doesn't interfere with this, 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 and this, and putting stipulations on yourself. Don't put restrictions on yourself. Decide to do something and do it really well. And that will serve you so well in your career and also in your professional relationships. And I just want to leave you with these final thoughts. Your experiences matter. Even your failures. Everything that you do matters. There's nothing that you experience or that you do that won't make you into the person that you're destined to become. Your thoughts matter. Your ideas, the things that you think that could be better, no matter who's telling you that things couldn't be better or that you can't do this, what you think matters, and you have a very individual perspective on how you can improve things around even where you work, where you go to school, and even the people that you're around. And your voice matters. So you may think sometimes, man, I'm just grinding, I'm trying to study for my step one and I want to do well, I just need to focus on this or that. What you have to say to your classmates, to your faculty, to the people that you're tutoring yourself maybe, really does matter. And if you feel like there's a way to make something better, go for it. Make it better. Who cares what anyone else thinks? You never know. You may just decide to invent something or stumble upon something that no one else had done before just because you were really passionate about it. So I just want to say a couple thank yous. This is our 3D printing lab, and this is a picture of my partner and my best friend, Aaron Damon, who's actually sitting probably 6 feet away from me right now, listening to me ramble on about all the research that we've been doing together. Aaron's a pretty incredible guy. Just to give you guys a little bit of a background, Aaron was an underwater welder and construction diver, a commercial diver. He worked at Yellowstone National Park as a park ranger, and he's just had all sorts of odd jobs. And he's really he's kind of the jock of the team. I'm kind of the nerd. So, you know, he's the one that tells it, Bill, don't put a round peg in a square hole, man. Like, you got to build it this way. And I'm the one that kind of brings the physics and the chemicals and all the sciencey things. And he's the one that brings the boots to the ground. Let's make these simulators this way. And Aaron's applying to PA school this year, so I wish him the best of luck. And, you know, he's going to be missed, but hopefully we can work clinically together. But, you know, partnering with the right people and finding people that you really click with is so important. And finding people of diverse backgrounds. You know, when you meet Aaron, you would never know the genius behind this guy or what he's able to do or what he's able to comprehend until you sit down, you talk, and you get to know him. And, you know, he's one of my best friends now, and we've really been in this together from the beginning. And then, you know, I just wanted to say thank you to some of my mentors. One's Eric Nottmeyer. He's a very renowned spine surgeon and professor of neurosurgery, did his fellowship at Barrow, Sontag Fellowship. And he's just been so good to me and teaching me how to be a good spine surgeon. And this is Dr. Mark Pickelman and Steve Edwards. Mark is a neurosurgeon that's now up in Eau Claire, Wisconsin in the Mayo Clinic system. And he's one of the most talented surgeons that I've ever met and one of the most caring individuals to patients. And he's the one that really showed me what it means to be a good surgeon and a good doctor, and not just to the patients, but to the people that you educate as well. And Steve is part of the spine team as well. And he's a nurse practitioner that operates with us. And it's just amazing the skill of these allied health have here at Mayo Clinic. And then this is my chairman, Dr. Q. Some of you guys may know him or have heard of him. He has a really incredible story. He's a migrant worker who became a neurosurgeon. And, you know, he's brought me on missions trip. This is a picture of us in Guadalajara, Mexico, operating together, doing some charity work. And, you know, he was the one that really pushed me into the person that I am today, the researcher and scientist that I am today, to always be better and never stop fighting, never stop punching, and to just never give up. And I just want to say a special thanks to, I'm sure none of them are there to hear it, but to all the techs that work in our lab, and to just the students that come in that love 3D printing and that want to make things better for us. And thank you guys so much for your attention, and I'm happy to take any questions that you guys may have.
That's great. Thank you, Dr. Clifton. That's really an incredible story. And thanks so much for the insight too, for just the process and the path that you went through to do what you did. And we have a long list of questions on the chat that people similarly are just really fascinated and curious to hear more. So let me start with a couple of those. One is just, how long does it take to build one of these simulators to really put all the different tissue types together and create that?
That's a great question. So the simulator itself takes probably about 20 minutes, 30 minutes to build. The 3D printing part of it, would take probably about a day. So now that we have 3 or 4 3D printers going, they're just going 24/7, and we just have a whole cadre of different types of spines and brains and skulls that are just kind of laying around. But the actual assembly of the models takes about 20, 30 minutes. So it's really great because the resident can hop out of the operating room and say, man, I really screwed this up today. I'd like to try it again some more. And then we can just have a model ready for them as they come out of the operating room.
So it looks like you actually moved the printer out of your bedroom and into a lab.
Yeah, my wife was happy to not be smelling that burning plastic anymore.
That's great. Another question. So can you build a simulation to practice on a particular individual structure? So very personalized, customized.
Yeah, that's a great question. And yes, and we have. So we've printed out models of patient-specific anatomy and planned the operation and done parts of the operation beforehand. And we have a couple of papers that are out there that we've talked about how we did that. So yeah, in the future, that's going to be something I think that's going to need to be explored more, is how cost effective and how better is it for patients that we do these procedures before we actually do them on the patient. And does it even matter if we do that? But in my opinion, I think it does.
Yeah, a couple of questions. So are you getting your data from CT, MRI scans of those individual patients then ahead of time?
All the
Sounds
above.
like so.
Yeah, all the above. And we use open access software. We don't have anything fancy, and it's stuff that you can download on your computer at home. And it's worked well for us. So when we funded this thing, we were paying everything for ourselves, me and Aaron. I took out the loan to get the printer and a lot of the supplies, and Aaron pitched in some of his money. And we're both making like $15 an hour. I'm a resident and he was a sim tech. So, it was very cost effective to begin with. So we try to keep it that way. But yeah, no, we use CT and MR data.
Okay. I think you may have addressed this, but the question is, can you explain how you actually use this in clinical practice, in addition to the educational methods? And are there objective methods, right, to kind of ensure that exact feel and the exact biomechanics between the simulator and the real tissue?
That is an awesome question. And that's what a lot of our research is going into now, is how do we move simulation from the subjective assessments that are there now into objective assessments? And no one has done that yet. Everything in simulation is still subjective. And that's what we're trying to change. And that was the title of this presentation, is simulation as a basic science. How can we move what we're doing from just Likert scales and how did this feel? What are your feelings about this? Or how did this person do, which is very subjective from person to person, into this patient did better, this resident did better. And I will tell you right now, that is not going to happen on just in my lab, in this lab, at Mayo Clinic, because grading residents actually is based on Likert scale. So everything is very subjective. There is no objective way that we grade residents on their surgical skills. So this, I'm hoping that this incites a riot at the higher levels to say, wait a second, how are we passing these people that are coming out and taking care of, patients? Like, you look at the data that's coming out of Europe, and it is alarming. It's alarming how little training these people get. So that is my career goal, is to create fair and objective standard of measurement of readiness for residents to move on to the next respective levels, which I think will make things safer for everyone.
Okay. Yeah, another question saying, I'm amazed and curious about the process to come up with a new simulated tissue. Can you talk a little bit more about what that process was like, right? In terms of like materials and do you have to, did you use any type of chemistry modeling software, or was it trial and error?
It was a lot of ruining my wife's pots and pans is what it was. She came home one day, and me and Aaron were in the kitchen and like burning stuff on the stove, and she's just like, what in the world is going on in here? And we had tried a few different compounds, and I'm not at liberty right now to disclose the exact makeup of the chemical structure, but we basically tailored a type of polyvinyl acetate, and we did it in a way where we could cross-link it with inorganic reactants. So we could basically take an inorganic reactant, we could do different levels of cross-linking and polymerization to tailor to the tissue that we wanted. And we did that with very simple and inexpensive reagents. And to answer your question, where that came from was literally organic 1 and Chem 1 knowledge. An acid goes to a base, positive goes to a negative. I can draw a chemical structure. If I do this and I have this many reactants and this many moles of this, it's really basic, you know, Chem 1 and Organic 1, which was kind of my point. If you want to pursue something, you don't need a title, you don't need a degree, you don't need to, you know, have a higher level discussion about it. You really just need to understand the fundamental principles and go from there. If you think about, and I'm not comparing this in any way to the light bulb or Microsoft or anything like that, but if you look at the way that those inventors invented what they did, they just went back to the very, very, very basic computational basics of what they were doing and then tried to build it up and make it better than what had been done before. And that's really what we did. So hopefully that answers their question.
Yeah, no, I think it did. This is an interesting angle. So were there any issues with administration, with an IRB or publishing in terms of your research being self-funded?
No. So, you know, if you're not officially industry funded and you don't have a grant, then you don't need to disclose it because either that comes out of a department or it comes out of your own pocket anyway. So we did have an IRB for all of our research, which is required through Mayo Clinic. But you know, that's one of those things I think had never really been done before. You know, and it wasn't being done for industry related research. It was done for educational research, which is, you know, probably why it was okay, but under the IRB. But you know, now that it actually is a product that can be marketed, then, you know, now we have disclosures and things like that. So, you know, and now that's a tough decision because you have to decide, you know, are you selling out, or, you know, how are you going to make this, you know, still translatable to institutions and make sure that they provide for it. And that's what's great about Mayo Clinic is that their number one focus is making patient care, education, and research better for not just Mayo Clinic, but for the world. So they only partner with companies that really have that in mind too. So we're excited to partner with a company that really wants to do that.
Okay, this is maybe a related question then. Having experienced the SIM industry and the costs of small scale manufacturing, have you considered open sourcing, licensing at least part of your recipe or design? Or is there a trade-off of control and quality not worth it? So what are some of the considerations that you've thought about kind of in that?
Yeah, that's a good question. And if you look up some of our publications, we make a lot of our STL files open access. So people can just download them and print them. And we just had a paper get published called the Spine Box, where we actually took a replica of one of the things that we invented, made our own STL file printable on any desktop computer, basically published instructions on how to make the cancellous bone, how to make the cortical bone, how to do some of the soft tissue, and that this could just be printed out and used in people's garages. So there are parts of our lab that are doing those things, and I think that that's extremely important. But to answer the question very specifically, the way that things work, in order to partner with people that have the resources to invest to make something really, really great, you know, and take it to the next level, that's where the industry partnerships are going to have to come in, because that's where the money's at. So, you know, as a physician at Mayo Clinic, you know, I really don't get any of the money from it. You know, I get to have my name on the patent and I get to be involved in the process, but I really don't get a paycheck from this. So that's the great part about working at a place like this, where you really do it because you want to do it for the right reasons.
Let's see, another one. So how do you determine which material properties are the most important to replicate in the simulators? Does that come from experience, or maybe you can expand on that a little bit?
Yeah, so that's a great question. So we did electrochemical data analyses using ohm meters and resistance on cadaveric tissue when we made our skin, fat, and muscle to try to replicate those properties so it bovied the same way. And when we applied electric cautery, how much did it smoke and how much, you know, did it cool? And then other was really just experience. And I will tell you from, you know, doing over 2,000 cases that everybody's different. So everybody's skin is different, everybody's fat's different, everyone's muscle's different, but there are certain texture qualities to it and the way that it's associated with the bony structures that is really the important part of the simulation of having to get that tissue off, seeing your landmarks for your safe screw placement. So that's really what we focused on.
Okay. So another just praise, this is very impressive. I think your work will have a huge impact on residents training. Another question more from the business perspective. Says that you were utilizing your own money at the initial phase. So what factors came into play to determine what was the right time to patent your innovation, and the patenting process is rather costly, and how is that kind of managed as well?
That's a great question. And, Mayo's a non-for-profit, so they have very specific ways that you can do this. I'm not allowed to sell anything on my own. I'm not allowed to patent anything on my own. Everything is done through the institution. So Mayo has a great setup where they allow you to have your own person that you can talk to, that you tell all your ideas to, that's not allowed to have any invested interest in what you're doing, that can just be your advisor and what the next steps are to do those things. And we had a big competition at Mayo. We have it every year called the Alligator Tank. It's like the shark tank. And you bring your ideas, and that was one of the pictures that I put was from, where you have a business pitch to a group of investors, and they decide who has the best pitch, and then that team gets money for patents and things like that. So we actually won first place at that this past year. And then Aaron was able to go to Minnesota and compete in what's called the Walleye Tank up in Minnesota. And that was actually a statewide competition for the best business pitch and innovation. And Aaron actually won first place in that as well. So I think doing those things really got the institution's attention and said, wow, there are actually people that want to invest in this and, want to use this. Maybe we can, help these guys out. But,
yeah, those are great venues too. And I think a lot of people are smiling and commenting that Carl, Illinois, our medical school, has a make-a-thon competition with a dolphin tank. So
awesome. It's just as formidable as a walleye.
There you go. There you go. We got a comment from some of our neurosurgeons that says neurosurgeons are not mean, and yes, we do see our families. So supporting you on that.
Amen. Thank you.
Not to turn away any future residents. Let's see. So one last question here maybe is, have you applied for SBIR or such funding, other external funding? Have you seen kind of a snowball effect of what you're doing?
Yeah, our work is so new that everyone's just trying to figure out where it's going to fit in. I'm personally going to apply for an R01 next year with the NIH for some of this research. Mm-hmm. And I really don't have a business interest. I'm not a businessman. I'm a physician. I'm a scientist. I really love what I do. I'm happy that Mayo wants to take it and run with it and give it to a company that wants to keep exploring how they can distribute this, across the world. But my interests are going to be specifically tailored for, my patients and then my residents, and just making sure that we make the best surgeons. That's my passion. I love teaching. I love interacting and seeing how excited these guys get when they get something in the OR. They understand a part of anatomy, or they look at their x-rays and they say, oh my God, I really helped that person. There's such a rewarding feeling to know that you operated on somebody and they thanked you for it, which is really incredible, because we rip a lot of people apart and you think that they're going to hate me for the rest of their life, but they come back and they say, thank you for doing the surgery on me. I can tell that I needed it. Mm-hmm. And having the residents see that they have the skills to be able to do that, is really the most rewarding thing to me. So I will just say, personally, I don't have a business interest. I don't have a small business. I'm a physician scientist here at Mayo, and they're kind of taking the reins on that. But, that's just something specific to me.
Yeah, no, it's great to hear. I know there's a few neurosurgeons, local neurosurgeons on the Zoom here. I don't know if any of them or other clinicians maybe want to comment. We can open up the floor here for anyone that wants to verbally ask questions or comment, reflect on what we heard from Dr. Clifton.
Yeah, if any neurosurgeons, I'll give them priority. This is Isam, because I'm a cardiologist, so.
Go ahead, Isam. Lead it off.
So obviously, the natural kind of question for me, cardiac, there's a lot of simulation for transcatheter specifically. So any barriers you think of simulating or doing something similar in terms of a heart with the tissue properties that somewhat, similar to the heart? That could also obviously vary based on pathology, but any basic science or engineering that barrier you think that would make this not possible?
No, that's a great question. And we've been working with our cardiothoracic surgeons here, and we've been developing an open chest model and some right atrial, I can't remember what they're doing, catheterization models. I'm not a heart surgeon, I don't know, but no, the material properties can be tailored to have any organ system. We've made livers, we've made lungs, we've made intestines, we made everything you could ever think of, and we really just do that based on the amount of polymerization and cross-linking of our polymer. And then we get the color right for the residents and, the different properties of the different layers of the tissue. But no, we've done hearts and things like that too.
Got it. Thank you.
Steve, this is Wael Mustafa, if you can hear me.
Yes, we can.
First, thank you, Bill, so much for this wonderful presentation. Your work will hugely impact the residence education in the years to come, especially in spine surgery. But as a cranial surgeon, I am very interested in, dealing with brain tumors, aneurysms, things like that. And this is the area that we are, lacking for residence training. As you know, there are more than enough spine cases that go around in every institution, but, clipping aneurysms are not that, familiar to a lot of residents anymore. Brain tumor surgery, skull-based surgery, things like that. I would ask you if you thought about incorporating fluorescence-guided resection for training when you do this brain tumor model.
Mm-hmm. Yeah, we have looked at that. We haven't been able to have the funding so far to be able to acquire some of those things, but like I mentioned, my presentation, like you mentioned, was focused on the spine surgical simulation because that's kind of where it all started. But we do have a sylvian fissure splitting model. We have meningioma model. We have interaxial brain tumor model for the residents. So, we are actively developing all these things and having, like the brain tumor resection models with intraoperative guidance, things like that. We're actively working on it. Where I'm falling short is having someone who's really interested in developing those things. I had my research year last year, so I did as much as I could in 15 months, and then I had to call it quits and be the clinical chief resident. But the technology is there, and it's all there. It's just a matter of someone that's willing to pick up the gauntlet and keep moving it forward.
Well, if you would like, that we can collaborate with you, in the future to develop those models that will be available for residents and medical students, we would be happy to. I'm not sure about the process, but I want you to know that you have, friends in town.
Oh, thank you. That means a lot. And I'd also ask that everyone get my email. I think Deborah has it, or whoever has it. Please send it to everybody who's on today. Please feel free to contact me again for collaboration opportunities. And also, especially to the medical students, if you guys have any questions about life, liberty, the pursuit of happiness, anything in residency, please do not hesitate to email me. I'd love to just chat with you and get your thoughts or answer your questions too. So if you guys wouldn't mind sending my email out, that'd be great.
Yeah, we'll take care of that. And thank you for that invitation to the students. There were a number of people asking about that, if there's opportunities to visit, to do, research rotations or time
Absolutely.
there in the laboratory and
Absolutely.
and really contribute. So I think that's a great way to build on this and extend this into collaborations.
Yeah. Come hang out in the OR. We'll do some cases together. Mayo's great for that.
That's right. Wonderful. Any other questions from the audience?
Yeah, I've got one question.
Sure.
Are the completed simulators shelf stable?
They are.
Awesome.
Yep,
It's amazing.
Yeah, we've had them out up to, Aaron, how long have we had those out? At least 2 weeks. Yeah, but that's open. That's not sealed or anything. So if we vacuum seal, we can probably do a month to 6 weeks.
Yeah, this is all very impressive. I've worked a little bit in medical in surgical simulation, and you've done in a short period of time what many people have struggled with for a long time.
Oh, thank you. Like I said, I'm looking forward to collaborating with your institution, and I'm sure there's much smarter people that can keep making it better.
Well, we're hearing many on the chat just saying thank you, thanks for the inspiration, the enthusiasm. It's really been wonderful to have you here, Dr. Clifton, and really as an inspiration to our college and community. Thank you for that, and we hope that many connections and collaborations will continue.
Absolutely. It's such a pleasure to speak to you. And again, I thank you so much for the opportunity, and please email me. Please contact me. And for the students, come do rotations, come hang out in the operating room, see what neurosurgery is all about. For me, it's the best job in the whole world. And like I said, I'm married. I have 4 kids. I love them very much. They all love their dad. I love my wife. You can do anything you set your mind to.
Wonderful. Thank you for sharing your story. thank you everyone for joining us, and take care. Have a good weekend.
Have a great day.
Bye.